Hello and welcome. I am Barbie Collins with the College of IST Development and Alumni Relations Office. Today, our presentation, Technology and Data Impacting the Epidemiology of COVID-19. Before I introduce our speaker, I'd like to welcome one of the College of IST's Alumni Society board members, Nikita Page. Nikita will be moderating the questions and answers for us today. Please post your questions and answers in the Q&A, and we will get to them as soon as we are able. Now, to introduce our speaker. Justin Silverman is an assistant professor in the College of Information Sciences and Technology, as well as the Department of Statistics, the Department of Medicine, and the Institute for Computational and Data Science. Dr. Silverman did his undergraduate work in both physics and biophysics at Johns Hopkins University before completing both his MD as well as his PhD in computational biology and bioinformatics at Duke University. Since moving to Penn State in June of 2020, Dr. Silverman has served as a COVID-19 consultant for state and national government organizations, as well as serving as part of the Back to School Planning Metrics team from June to September of 2020. More recently, Dr. Silverman has served as the statistical lead on the SARS-CoV-2 Wastewater Surveillance project that is running here at Penn State. Today, Dr. Silverman will share a high-level overview of 3 projects related to the epidemiologic surveillance of SARS-CoV-2. This work has been published in both the journals of Science and Science Translational Medicine and has been featured in over 400 news articles, including features in The Economist, CNN, The New York Times, and The New York Post. Dr. Silverman, thank you from the College of IST and the Alumni Association for presenting to us today.
Thank you very much for having me. It's as someone who's sort of new to the Penn State community, it's wonderful to get to interact and be part of Alumni Weekend. Can everyone see my screen? All right. I'm going to assume yes. Okay, so today I'm going to be talking about some projects I've been doing with SARS-CoV-2 surveillance. And just to give you a little bit of a background, what I work on is sort of broad. I primarily do things in bioinformatics, particularly genomics, as well as some clinical informatics, analyzing electronic health data. At the start of the COVID-19 pandemic, I found myself in an interesting position where a lot of the skills that I had in terms of data analysis could be used for helping to understand what's happening with COVID-19 and analyzing some of the data that was coming in, especially early in the pandemic. Beyond that, I like to say that my lab focuses on pretty much whatever's fun. I have projects in even submarine maintenance and all kinds of stuff in the School of Ag. It's wonderful being here and being in IST, partly because I get to work on all kinds of interesting problems all over the place. But today I'm going to be really focusing on some of this epidemiology work. So I recently moved to Penn State, and leading up to the move, which occurred around June 2020, I was really starting to shut down some of my research programs and prepare for a quiet move in the summer. And my son had recently been born. It was a kind of busy time as it was. We were trying to pack up the house, and then we start hearing about COVID-19. Originally, I thought, okay, well, that's not my area of focus. I'm not going to be working on this. But I ended up having a few friends, old colleagues who essentially pointed me at some of this data and said, something's interesting happening here, and you should look at it. And I'll talk a little bit about what ended up happening, but essentially I went from having a plan of having an incredibly quiet summer and a slow move to having to take a couple months off of everything just to deal with this research program, and then ultimately deal with reporters and deal with kind of everything that happened afterwards. So to give you some context as to why did this get so much attention? What did we find? I want to just rewind to what did we believe was happening with COVID-19 back in March of 2020? Well, around that time, what was widely accepted was that the virus had a 6.4-day doubling time. Just in case people don't know, a doubling time is this sort of fundamental quality of an epidemic. What it is the measure of how long it takes for the number of infections to double. Epidemics often follow exponential growth. And one person infects two more who infect two more, and you get this exponential growth phenomenon. And so the doubling time is this fundamental quality in thinking about how fast an epidemic grows. 6.4-day doubling time is sort of a medium speed. It's not the fastest, it's not the slowest. This is what we originally thought. We also thought that between March 8th and March 28th in the US, there were 120,000 infections. This is what you got from, for example, Hopkins COVID dashboard or some of the other trackers that were tracking the number of confirmed cases. We also thought that the infection fatality rate, which is a measure of the probability that someone who's infected dies of the infection, was around 3.4%. This is really what got national headlines early on, right? That the high mortality, this idea that 34 out of 1,000 people would die from this if infected. At this point, starting towards the end of March, the time period that we're talking about, some people had started thinking that maybe that was too high, maybe it was closer to 1%. But still, we were talking about single-digit percentages. So what we suggested, and this is one of the reasons it got so much attention, was that it was actually a much faster epidemic, more than twice the speed in terms of its exponential doubling, right? And so when we're talking, this is all on an exponential scale. So 3-day doubling time is massively faster. That instead of 120,000 infections during the same time period, there were greater than 8.7 million in the US, more than 80 times the number of infections. And together, this had this weak suggestion, right? If you think of there's more infections, it weakly suggests that the infection fatality rate may not be as high as initially thought.
Dr. Silverman, question from the audience,
Yes.
real quick. Who initially shared that infection fatality rate?
So that's kind of hard to pin down. Some of the initial fatality rates came out of the WHO based on data out of China. There were also then similar numbers were being seen in, for example, Lombardy in Italy. And I can talk a little bit about why we originally thought it was so high. I'll talk about that a little bit later in the presentation, but hopefully that answers the question. So basically, it was WHO from data out of China originally.
Great, thank you.
So this is why, this is why basically this got so much attention. But now I want to go into, well, what did we do? So the idea was under this heading of what I'll call non-specific surveillance, okay? And to define what that is, let me contrast it with specific surveillance. So specific surveillance is what I call basically what everyone was looking at. This is, for example, the Hopkins COVID dashboard, which was tracking the number of cases, not just in the US, but also around the world. I'm just focusing on the US. These are confirmed cases based on molecular diagnostics, highly specific. Essentially, you don't get many false positives this way. This is also quite biased. If you think back to March of 2020, not only was there a shortage of reagents for the test, and the test hadn't been rolled out, a lot of clinical diagnostics labs hadn't developed a CLIA certified assay yet for COVID, but beyond that, there were even a shortage of swabs. It's like sterile swabs, right? This kind of trivial thing that you wouldn't have thought of, but essentially, it was very hard to get a COVID-19 test or SARS-CoV-2 PCR molecular diagnostic assay unless you were in a hospital. For example, if you were in New York in the midst of the peak in March, pretty much the only people who were getting a test were people who were in the ICU or looking like they had to move to the ICU. So you're getting a very biased view of not only how many infections there are, right? You're going to be missing a lot, but also you're getting a biased view in terms of, for example, the mortality rate. You're only seeing the sickest of the sick. So our idea was to, well, first off, basically, you should realize no data is perfect, right? That's sort of a mantra you can say everywhere. Epidemiologic data is a particular type of awful, right? And specific surveillance, right? Individual-based testing can be really difficult to work with. So our idea was, well, what if you traded data that was highly specific for data that was non-specific, but not as biased? Okay, and this leads to sort of two projects I'll talk about. One is syndromic surveillance and the other is wastewater surveillance. So let me give you an idea of what I mean by non-specific. So what if you just asked people how they were feeling? Obviously, you're going to get a lot of false positives, right? It's not a specific assay, but it's also incredibly easy to do. You're not going to miss too many people. There's no issues of reagent limitations or resource limitations. Now, this seems kind of ridiculous, right? Well, okay, we're not just going to ask everyone how they're feeling, because you might just get, I don't know, I had a bad Tuesday, right? You can't really make sense of that. So instead, we're going to ask specifically if they have influenza-like illness, which is a specific syndrome that is defined as fever and then one of either cough and or runny nose. Now, this doesn't look exactly like COVID. Runny nose is not particularly common in COVID-like illness. But still, fever and cough, there's a pretty good overlap with how COVID initially presents. And so it wasn't just our idea, but at the time, a number of people thought that you might be able to use influenza-like illness as a marker for tracking COVID. Okay. Now, none of this would be, so basically you can do this across the entire country. That's the idea. Now, none of this would be possible if we had to go out and set this whole system up from scratch. Luckily, the CDC had been running this thing called the ILINet, which is a surveillance network for the past 10 years all across the country. Now, they didn't set this up for COVID. They set this up for influenza after H1N1 as an early warning system to detect when you had a particularly bad influenza year, right? To basically to have early warning so you can plan and get resources to where they need to be. This is a huge surveillance network. There's 2,600 Sentinel providers. They're all outpatient providers around the US. So what that means, basically there are outpatient clinics and clinicians. For example, Penn State Student Health is one of them, where if a patient goes and sees a physician at one of these Sentinel providers, then you'll be asked, do you have fever and or cough and or runny nose? And then they just track yes or no. And at the end of each week, they tally up how many patients they saw and how many of them met the criteria for influenza-like illness. And they send that data to the CDC, who aggregates that data at the state level and makes that data available each week to its publicly accessible data. This captures about 60 million outpatient encounters each year. So just to be clear, that's first off, it's a tremendous amount of data. And the other point is that these are all outpatient, right? So you're not just getting the bias of seeing the sickest of the sick people. Now, you are only seeing people who decide to go see their physician, but at the very least, when we're talking about March of 2020, this seems like an improvement compared to only getting data from people who are in the ICU or in the hospital. So this is the data set. Right? And one of the important parts is that we had data going back to 2010. Now, as I already said, this is non-specific. We're going to capture people in this data that don't just have COVID. We're going to capture people, for example, who just have a common cold, right? That can look like influenza, right? They get a fever, they get cough and or runny nose. Well, so this is where some of the statistical modeling came in. And I'll just briefly give an idea of what the problem we were trying to solve is. And this is how we set it up. This is a bit of a complicated plot, so I'll walk through it one piece at a time, and that's my fault. It's not the greatest plot. But here's just 4 example states. Let's just look at New York for the moment. The black lines in the back, these are 9 years of historical data of the proportion of patients showing up to their physician with ILI each week. Okay, so the center of the plot is centered at the middle of the epidemic year, as defined by the CDC, which is winter, when most people get sick. And you can see that historically, there's this very regular pattern where you've got low numbers of people showing up to their physician with ILI in the summers, and it peaks in the winter. Now, of course, there's variation. You know, some years are worse than others, but in general, there's this common pattern there. And each state has their own sort of fingerprint of this is how ILI looks at a state level each week in the year. Well, so our idea was that historically there wasn't COVID. So what we can do is build a model for what typical seasonal variation of ILI looks like. And then we take this year's data and we subtract from that this historical model. So in red, what you're seeing is this year being, I'm talking about the 2019 to 2020 year when we did the study. There, what you saw was that it was a particularly bad year for upper respiratory infections, just at baseline, even up to December. But then once we start getting into February and March, we saw this massive peak. We called this the ILI surge. We saw it pretty much in every state around the US, but to different degrees. And so what we're trying to do here is subtract, say, which part, how much of the ILI that we're seeing is due to potentially this new thing on the block, COVID, compared to just typical seasonal variation. So we take the red line, we subtract from it our model of historical variation in ILI. And that's what gives us the blue, which is a model. It's not a line, it's a ribbon because we have uncertainty in that. But this is our estimates for how much of the ILI could not be explained by typical seasonal variation. Okay, for example, cannot be explained by influenza, by respiratory syncytial virus, by adenoviruses or other coronaviruses that are endemic in the US. And so this is the signal that we think, this could be COVID. Now, it doesn't only capture COVID. It captures basically anything that is atypical. So for example, in Washington state in November to December, you see that there's a big peak. It turns out that there was a massive and quite unusual outbreak of respiratory syncytial virus in November and December in Washington state. So we capture that. But this excess ILI signal, this blue, what we start seeing is it really picks up in February to March. And in particular, starting March 8th, this signal starts correlating extremely strongly with the pattern of COVID spread around the US. Places like New York have more excess ILI than places like Iowa, which had very few cases. Okay, so now we're basically capturing that there's this excess proportion of people showing up to their physician with ILI. And we can translate that to a number, how many people are showing up to their physician with excess ILI. And just to give a nice visualization of what I'm talking about this correlation with the spread, this was a plot made by The Economist based on our work. And what you have is so for 1 week in the year, March 22nd to March 28th, you have a plot showing on the y-axis, the number of new confirmed COVID cases that week. And on the x-axis, this excess ILI that we're estimating. And what you can see is that places like New York and New Jersey, they are definitely standing out, right? We have more excess ILI in areas that we have more known COVID. This is just 1 week. What ended up happening is the signal got stronger and stronger and stronger as time went on. What was remarkable is what happens when we say, okay, so there's this correlation, but how many people are actually implied by the excess ILI? Not just is it correlated, but trying to put a number on that. And so to do that, I want to explain how we did that. I want you to think of a typical course of the COVID illness. So imagine that there is a population of people who are exposed all at the same time. Okay, we call that, let's say, day 0. After some period of time, a subset of those people will go on to become infected. A subset of those will go on to show symptoms. A subset of those will then go on to seek medical care. Some will become hospitalized, some will go to the ICU, some will die. It's at this point that they seek medical care that we start seeing them in different data sets. For example, confirmed cases end up showing up as a subset of those who seek medical care. ILI, we think, represents a larger proportion. But it's hard to visualize here, but we also think it's a less biased, right? It's not just the people who are going to the ICU. Now, one more point I want to make on this that will come back later is that in general, we don't think that an evidence suggested that we were potentially missing a lot of infections and a lot of symptoms, but we're not missing as many people who die. Essentially, March and on in the US, if you died from something that wasn't clearly not COVID, you typically had a COVID test. And we weren't missing a tremendous number of deaths due to COVID. I can talk more about that because there were some mixed reports coming out early on, but in the US at least, we weren't missing a tremendous number of those, but we were missing a lot of people, for example, who went to see their physician, didn't get tested. That point will come back a little later. Anyway, so we now, from the previous slides, what we now have is an estimate of the number of people who are seeking medical care and have ILI. And so the question is, well, what does this imply about the total number of people who are infected? Well, there's some interesting data that has been collected that helped us get from this seeking medical care compartment back to the number of infected. So for example, we know that historically there's a sort of fixed relationship in terms of the percentage of people who don't feel well, have ILI, and of those, how many go on to go to their physician? I mean, generally there's just like a fixed percentage of people who say, look, I don't really care how I feel. Unless I'm dying, I'm not going to the doctor. And that number really hasn't changed for many years. In fact, a lot of the evidence showed it wasn't even changing in the beginning of COVID either. Okay, so we can basically use that number to estimate the symptomatic fraction. Then there were some interesting early cases that happened that allowed us to also back out the estimate for the number of infected. So for example, the Diamond Princess cruise ship. This was a closed population that many of them, pretty much everyone, was exposed to COVID. And we have data there that helped us figure out, well, of those people, how many ended up going on to develop symptoms. So you have these special case studies that allowed us to at least put some estimates on the relationship between the number of infected and the number who develop symptoms. And when you consider uncertainty in all these estimates and you turn the crank, what we got was that between March 28th and March 8th and March 28th in the US, we estimated at least, so a lower bound of 8.7 million new infections across the US. Right? And this is in contrast to the 120,000 that were officially reported, or that we captured with molecular diagnostics. Now, at this point, I thought, well, this is a waste of time. I must have messed up somewhere. This can't possibly be right. And so I put this work down for a couple days and just said, you know, so much for me trying to throw my hat in the ring. And, you know, obviously I don't know this, I messed up here somewhere. Well, that's when that friend I'd mentioned earlier contacted me, and he'd been doing his completely own independent study. And using a completely different approach, he'd come to a nearly identical number. I mean, he came to like 9.1 million, whereas I came to 8.7. So we compared notes, and this is where I started thinking that maybe there's something to this. I was still quite skeptical, but let me just briefly describe his approach. So he started from a standpoint of maybe the viral doubling time that was being reported was wrong. So he reanalyzed some of the data coming out of China particularly, and then some of the data that was coming out early from New York and Italy. And he came to the conclusion that it was probably closer to a 3-day doubling time. Much faster. What the plot I'm showing was a plot made by the New York Times on April 20th, showing that actually what played out in the US that's pretty reasonable. The initial epidemic doubling time, right? And it's only the initial doubling time that we care about here, because the doubling time does change and it decreases over time, which I can talk about later why, but it's the initial doubling time we care about. The initial doubling time across in the US and across a number of other countries really did look much closer to a 3-day or even a 2-day doubling time than a 6.4-day doubling time. Right? A 6.4-day doubling time is would be fairly unusual. So this seemed to hold up. Now the question is, well, given that we sort of have an idea as to when this started, right? We started seeing cases pop up all over the place. We at least have we know that pretty much at latest, the epidemic in the US started on January 28th in Snohomish County in Washington. Well, making some assumptions and starting with 3-day doubling time, you get a tremendous number more cases by March 28th than if it had truly been a 6.4-day doubling time. And so we both ended up with these estimates saying that there were a lot more cases than had previously been expected. And as I had alluded to, we ended up with almost identical results. So this is the point where we decided, you know, we're both skeptical, we still don't know what's happening, but at the very least, we should write this up because it's interesting and, you know, science, put this out there and get feedback and see what people think. And, you know, maybe we're right, maybe we're wrong.
Dr. Silverman, quick question. Of course, you're working with a vast amount of data coming from various different sources. And of course, us being a technology-oriented school, what kind of tools and technologies did you utilize when testing and analyzing this data?
So I've developed a lot of, beyond the sort of trivial things, like I used the R programming language because I like it. And, you know, I used GitHub because that was where the data was stored. What my research primarily is statistical methods development for a lot of time series data and a lot of count data, things that were, you know, very much what we were working on here. I can go into details about some of the methods I've developed, but basically everything was, you know, my own technologies that I've been developing over the past 10 years.
Very cool, thank you.
Okay, so one of the things, so now we have we're putting this paper out. And one of the things that we included in the paper was this one figure that was, this is a preprint at this point. We put this figure out that was, you know, a breakdown of that 8.7 million number by state and represented as the percentage of the state's population that we think was infected, or at least that the ILI data suggested was infected between this date of March 8th to March 28th. In particular, you know, you see that some of it looks very reasonable, right? You've got New York and New Jersey that are pretty much leading the pack. But the number that we suggested was, again, much higher than others. If you looked at case counts, the number that was expected was that about 0.1% of the population was infected at this point. We suggested that a little over 9% of the population was infected in this 4-week time period, much higher. So this is when we get contacted by the New York governor's office. Well, this is when The Economist picked us up. This is when we got contacted by New York, as well as a few other areas like North Carolina and the CDC. And essentially we're asked to present and look at some of their data and help them make sense of what's going on. And because we've basically this alternative way of looking at it's a completely alternative story about what's special about COVID, as I'll highlight in a minute. And basically what we said was, look, we don't know if we're right or wrong. We put this out there and we stated all the limitations of the work because we thought it was interesting and it was hard to ignore. And what we told them is, well, we really think what you should do is a huge serology study looking for antibodies against the virus. Because instead of just looking at cases, antibodies at least stick around for a long time. So you have an idea of not just who's currently infected, but who has been infected. So they ran this massive serology study all over New York State. And the result came back as 13.6% for a similar time period. Now, again, case counts were saying 0.1%. We were saying greater than equal to 9%. It came back at 13.6. And this was sort of a, wow, this experimental validation that we're not crazy. So this is really when I think I started believing that there was something here. Even to this point, we'd put the paper out, but I had just been saying, this seems ridiculous. I don't know, but at least we should make this publicly available. And this is when it seemed like we had 2 lines of evidence that came to similar conclusions. We then made a prediction. The prediction was validated experimentally. There's something maybe to believe here. All right. So when you put this all together, this really does suggest an alternative conceptual model for COVID. Again, early on, the initial reports, and I'd say that still what stayed in the kind of collective consciousness is this idea of defining COVID as this incredibly deadly disease, that is what makes it special. What I mean is, there's obviously tremendous numbers of pathogens that are circulating around. Why COVID has brought the world to a halt over the past few years, I think, is a really interesting question. Why, for example, is it that the SARS-CoV-2 virus has led to these early reports of hospitals being overwhelmed, right? The horror that was happening in New York City or in Italy, and that has subsequently happened all over the place. Well, instead of thinking of it as, well, this is one way of thinking of it, and is that this is happening because this is such a deadly virus. I think that's what a lot of people think, and that's what a lot of people thought at the time. What we're suggesting is that maybe that's not the defining characteristic of COVID. It is deadly. I mean, it's deadlier than the flu. I mean, but really what's truly remarkable about it is how fast it spreads. And this fast growth, in coupling that with the fact that you have a tremendous number of people who have mild infections. Right? Those two together are sort of needed in order to explain what we were seeing, both and explaining the fact that there are more infections than we thought, and it's growing faster. You need to have something else to explain what everyone was seeing in the hospitals. And the conclusion is that they're probably more mild infections. Coupling with that, there is also the suggestion that the infection fatality rate is lower. Our estimates put it probably closer to 0.5 than 3%, 6 times lower. But in total, this was, I think, a fairly different way of looking at COVID. And I still think that the idea that's in the people's collective consciousness is largely based on those initial news reports And I think that we haven't given that up. But I think that there is now tremendous evidence to suggest that it's not the case. You know, it really is. It has a high infection fatality rate, higher than influenza, but that's not necessarily a defining characteristic. So this question of how deadly really did become central. Now, what I'll say is that in our initial paper, we never commented on the fatality rate. We actually tried not to because we thought that that was going beyond what the data could say. We personally had certain beliefs, but we never put that out. What really happened is that essentially I was in the uncomfortable position of watching as the science that I put out gets spun. It got spun and the whole thing got politicized. And basically our results got spun by both sides of the aisle. On one side, you had people taking our results and saying, well, this is evidence that a lot more people have been infected. This is no deadlier than influenza. This is a hoax. On the other side, and somewhat equally ridiculous, is people basically saying, well, we should be panicking so much more because there's been so many more infections. So it was a pretty uncomfortable situation to be in, and there ended up being a lot of work trying to work with reporters and making sure that stories were trying to be balanced and trying to view the entire situation with some moderation. And ultimately, we were approached by one reporter who said, well, why don't you just write your own article, basically. And so this was the conversation. We were approached by the others saying, we'd like you, they wanted us to write an article about how deadly SARS-CoV-2 was. And what we said is, well, we don't know how deadly it is, but what we can do is we can write an article saying why it's so difficult to actually pin down the infection fatality rate. Now, one of the things that was happening is there was a lot of confusion about the infection fatality rate. You were getting, estimates, early estimates were really pretty much focused on this 3.4% number. But then as time went on, estimates started to vary. We were one of the, basically the implications of our work was one of the early ones that kind of led to this idea that maybe it was lower than previously believed. Many people took this as evidence that they were being lied to. There's this uncertainty, why can't you just count the number of people who are infected, count the number of people who died, divide, and there you go, that's your answer. Why should there be any uncertainty? And so we wrote this article really to address that concern. Why is it so hard to figure out the infection fatality rate? So the answer is actually fairly simple, right? We already described that it's hard to know how many people were infected. Right? So the infection fatality rate is related to, right? It's defined as the percentage of people who are infected who then die from the infection. You have to know how many people are infected. We've already talked that that's difficult. How many people died? That's less difficult because it's hard to miss when someone dies. But then the other thing that's really critical is the time lag between infection and death. You can't just count the number of people who have died to date and the number of people who have been infected to date, even if you knew the true numbers. Because the people who have died, they were infected before. The people who are now infected, basically you need to align these so that you're really looking at a cohort of people. Of this cohort, how many die? And early on in an epidemic, when it's growing exponentially, you can have far more people who have been infected who haven't had a chance yet, right? They haven't had the infection long enough to die of it. So you have to really know what this time lag is between infection and deaths, especially early on in an epidemic, for accurate estimation of the infection fatality rate. In fact, even being off by like a day or two in terms of the average time lag is enough to change the implied infection fatality rate by a factor of 2. Basically, all this together means that there's a tremendous amount of uncertainty. Now, the other thing we did say in this article is that we summarized some of the literature that had been coming out more recently than our article, and it really did look like 3.4% number was unreasonably high for the general population. And really, you have to break it down by age and risk. But even then, just this overall 3.4% number, it's hard to get to that reasonably. And sure enough, I think the current best estimates really are closer to around 0.5, 0.4, 0.5%.
Dr. Silverman, quick question. Even for the numbers that you were pulling to see how many people actually passed away from COVID, were you certain that those numbers were accurate in terms of were the biopsies that were kind of provided to you actually confirmed that in fact those deaths were from COVID and not other related diseases?
So there's been a lot of uncertainty about this. That's a great question. Early on, there was both, in the news, we've seen both things, right? There are going to be people who are misdiagnosed as having COVID when they didn't have it. There are also people who die, especially early on, no one realized it was COVID. There were some early reports that we were massively missing the number of deaths. There's 4 times more people who are dying of this than we thought. Not in the US, right? That has been sort of debunked. There's also been some concerns that we're massively overdiagnosing deaths from COVID. I think that has also been largely debunked, right? What I mean by that is we've gotten pretty good now at diagnosing, is this COVID or is it not? Early on, there was a lot of uncertainty, but now the estimates have not really changed. Even though you're getting better molecular diagnostics, better protocols for autopsies, we've gotten pretty good at diagnosing COVID. So I think that we're not, yes, there are some people who get misdiagnosed in both directions, but it's just not that much. I think maybe we're talking about somewhere between 4, at most 4 to 10%, like some 4, maybe on the outside chance 10%. But still, that's not nearly as large as, for example, being off by the number of infections by a factor of 80, right?
Right. So you're saying that basically seeing the numbers now and seeing the confirmation of we know who actually is infected or who passed away from COVID now, you're able to validate that data from previous. People have continuously studied this question, and the studies have started all coming to the same conclusion, using different methods as we're getting better and better at diagnosing, as autopsy procedures are getting standardized. We have a good idea as to who's passing away from COVID, and those numbers haven't really changed compared to where they were in, for example, June of 2020. So it of course we could be missing a ton, but I think it's highly unlikely. The evidence doesn't point to that. Great, thank you very much.
All right, so I'm going to put aside this issue of influenza-like illness, infection fatality rate for a minute, and I want to talk about another project that came up. So basically what happened after the last work is I ended up taking about a month or 2 off because it was essentially consulting for government organizations took up a lot of time. Talking to reporters took a lot of time, and honestly, just some burnout of, as I mentioned, the fallout of having your work being politicized so extremely was difficult. So I took a little bit of time off, and then ended up coming back to COVID research when a lot of these viral mutants started showing up on people's radars. Now, just to give you some context, viruses naturally mutate. Not all mutations confer a selective advantage. A lot of mutations are relatively neutral. They, just mutation and error introduced into the viral genome because the replication is not, 100% perfect. However, there had been, and there still is, a lot of concern about new viral mutants arising that could confer a selective advantage. New viruses that could evade a vaccine, for example. A lot of these early reports, the reports of viral mutants started almost immediately in the beginning of the pandemic. And most of them sort of petered out. Someone mentioned here's a new mutant. It's taking over. It must be conferring a selective advantage, and then it sort of disappears, or it doesn't. It's not borne out in when people go in and actually study the infection fatality rate or the infection rate of one mutant versus the other. Now, part of the way to understand why this is happening is a survivorship bias. Essentially, the only viral mutants that we end up looking for are the ones that seem to be growing in the population. But a mutant can grow just because it found an open niche in the population. One mutant that doesn't have any particular selective advantage ends up landing into a small population of people who are all in close contact to each other. For example, like the Hasidic Jewish population in New York, this happened. And that one viral mutant gets passed around. Not that it has any selective advantage, another mutant would probably just do it just as well. But when you zoom out, it looks as though there's this one mutant that's causing all of these cases. There's this bloom. So we study it. And right, this is the survivorship bias. The only mutants that we end up really looking for are the ones that seem to bloom in the population. And so there's this question of, when you have a mutant, how do you determine if it truly does confer a selective advantage versus this is just some neutral evolution and it just found an open niche and it's going to burn itself out? So we've been sort of tracking this for a while. We've been working with some people in England in the COVID genome consortium, a number of researchers there. And starting around December of 2020, a bunch of people started noticing a really weird phenomena happening. So to understand this, I want to describe how we do the assay for the PCR assay for SARS-CoV-2. Really, we're testing for the presence of 3 different genes: the S gene, the N gene, and the ORF1ab gene. Just because in case there's some mutation, you still have other targets that you can assess. You don't want to just miss an infection. Well, starting around December, people started noticing in England that there was a tremendous number of infections where they were testing positive for the N and the ORF1ab gene, but they were testing negative for the S gene, what's called S gene target failure. And looking back from October, and then tracking this into January, what they noticed is that these target failures became more and more and more common until they were basically the norm. Almost everyone was testing, everyone tested positive had this S gene target failure. This seemed potentially highly non-random, and it turned out they named this particular variant the B117 variant. And so I ended up getting brought on basically because they wanted some statistical work to say, is this random? Is it not? And trying to make sense of all of this data. And we concluded that it really wasn't random, that this probably did confer a selective advantage, which has been borne out in studies subsequently. Just to give you a sense of what I'm talking about, here's the relative abundance of different mutants in England from March to March 2020 to 2021. The B117 variant that we're talking about is this purple one. And what you can see is that it basically takes over. You can also see that there's been a lot of cases in the past that looked very similar, but didn't actually end up getting borne out. Like the darker blue purple one here, the B1, it's a very, unfortunately, they have terrible names, B1177. This one looked like it was going to be taking over, and then it didn't, right? It burned itself out. So subsequently, B117 has become a bigger issue. It does confer a selective advantage. It is more infectious, and it does confer a higher mortality rate. Luckily, it is also covered by vaccinations. People are still likely to potentially get it, but they still have a very low mortality rate from B117, even if they're vaccinated. So these viral mutants became a pretty interesting topic. Briefly, I also want to mention wastewater surveillance. So this is an interesting idea that falls into this category of nonspecific surveillance. Like the idea of what if we just asked everyone if they were sick? Here the idea is, what if we just tested the wastewater for the presence of SARS-CoV-2 and used the concentration of the virus in wastewater as a measure of basically the number of people in the population who are sick or who are infected? So this works because we know that SARS-CoV-2 is shed in the stool. And some early reports out of Europe suggested that actually it could be amplified out of wastewater. And so along with 3 other faculty members here at Penn State, we as a consortium started this wastewater surveillance project here at Penn State. So to give a little bit more idea of the problem and why we're setting this up, right? The question is, we want to bring students back in the fall because students need education and we can't just shut the university down. But how do we do it safely? Well, you need to have an idea of when there's too many people on campus who are sick and it's getting out of hand and you can shut it down, versus, you have a small number of infections, we can do contact tracing and isolate them and keep everything, in control. Well, we did some early math and basically said that in order to achieve that level of surveillance and control, you'd basically need to test about 5,000 to 10,000 people a day, out of a population of around 50,000, which is unreasonable. Not only is it not, you don't have the manpower to test that many people, but imagine being a student getting tested once a week for COVID. Imagine, it's a risk just having that. You're trying to have everyone social distance. Where does everyone go to get, where do 10,000 people go to get a test, or, in a week? So the idea of wastewater surveillance is, rather than testing 10,000 people a week, maybe you can just test one wastewater sample. Everyone has to poop. We know it's shed in the feces. And if you look at the concentration in wastewater, it's a marker for the number of people in the population who are infected. Turns out it actually works quite well. We were able to get basically get a working system, a surveillance system, up and running in about a month and a half over the summer of 2020. And I'm just showing you some of the early data out of it. Basically, what you see is that before students come to campus, there's nothing, or it's essentially below the viral detection limit, which is this gray line. The red dots are the log viral count per milliliters of wastewater, so a measure of the concentration. The blue here is basically my model helping interpret the data. Students return to campus on August 17th. We see a small bump. Some students are coming back. A lot of students live off campus. First day of classes, you get another bump. People returning for the first day of classes, going out of campus. Subsequently, this dropped down again. Contact tracing isolation helped a lot on campus. Luckily, we were able to have a safe year. But this has been a really interesting project and we're continuing it. Anyway, with that, I'd love to take any other questions.
Yeah, I do have one question here. So, given so many reports early on that had such uncertain data and various methodologies being used that produce various IFRs, do you have thoughts on how the states were using this uncertain data to mandate closures of schools, restaurants, other facilities?
I do. That is a incredibly difficult question. I guess are you asking how were the decisions made, or there's a lot of ways to potentially answer that.
Let's start with how were the decisions made, and then based on how they were made, what were your thoughts on the data they used, and how they kind of executed the procedures?
So a lot of the shutdowns were not due to, they weren't mandated by data, essentially, or they weren't directed by data making those decisions. Obviously there was some data, which is that COVID is spreading through the US population. But the question of, is it necessary to shut down? What are the non-pharmacological interventions that are efficacious and that are warranted by kind of a risk-benefit analysis? We don't know. We didn't know. No one's really ever tried that before, to shut everything down like that. What I'd say is that from a political level, the decision was less based on, for example, simulations or discussions with epidemiologists, and it was more based on demand by the population. A lot of states, there was this, you started having increasing non-pharmacological interventions in New York, and there was pressure on politicians to expand this. Obviously, this is an incredibly complex conversation because there were so many decisions that were made in so many different places in so many different ways. But I will say that overall, it's really a hard question to say, is it reasonable to for example, shut down? Not only is it almost impossible to have enough data to answer that question, but it's also really a question of values, right? We know that there was a hit to the economy. We know that people who were low income and disadvantaged in the first place were differentially affected by the lockdowns. What's the benefit of that compared to the increased mortality risk to a largely older population? And how do you balance that with these non-pharmacological interventions? It's almost an impossible question to answer using data. It really is almost a value-based question.
Yeah, absolutely. And thank you for your input. That is definitely an incredibly hard question to answer. So we'll finish up with a pretty easy one. How did you get your interest in epidemiology?
Well, I have medical training. I did an MD at Duke. My plan had always been to go into infectious disease. A lot of my research is in microbiology to begin with human gut microbiomes. But even then, I had not been planning on really entering into any of this if it hadn't been, I had that one friend who basically pushed me to say, we need your skill set. Can you help us? Maybe you should look at some of these ILI data to help make sense. Early on, I got hooked up with the CDC and started participating in some of these forecasting challenges, trying to help forecast the spread of COVID around the US, because it seemed like, I could help. And then it just then we found the signal in the ILI, and it just sort of snowballed.
Great. Well, thank you very much, Dr. Silverman.
Well, thank you guys very much.
Well, if there aren't any other questions, I'm going to say thank you to Dr. Silverman and to all of you for joining in this conversation and presentation. And I hope you have the best of time during the virtual We Are weekend. Thank you so much.